Right, so welcome everyone. Welcome to this month's and the first Liverpool Dementia Ageing Research Forum of 2023. Very exciting lineup today. We've got a fellow colleague from the University of Liverpool, and we also got someone from University of Nottingham. So we've got Dr. Dalia Tsimpida, who is a lecturer in public health, who will share her research. Oh, sorry, can everyone please mute themselves? It's quite distracting, thank you. And we also have Dr. Eithne Heffernan from the University of Nottingham, who is a senior research fellow there. So both of these researchers are doing fabulous work on hearing loss and dementia, and it's something we've not really had featured in the forum to date. So it's really interesting and also learning experience for me to find out more about this. And as always, there'll be plenty of time for Q&A afterwards. So we've got about 20 minutes from each presenter. And the first one will be Dr. Eithne Heffernan, then we'll move over to Dr. Dalia Tsimpida. And throughout, please post your questions in the Q&A in the chat function. We will pick them up after. And if you are on social media as well, you can use the hashtag Liverpool Dementia. We'll be simultaneously on social media as well if you have any additional comments or thoughts. And we'll have a good Q&A afterwards. So without further ado, and many more people waiting in the waiting room, which I have to admit now, Eithne, over to you. Really looking forward to your talk now.
Thank you. Thanks so much for having me. So as Clarissa said, today both Dalia and I will be discussing the link between hearing loss and dementia. Sorry.
Ja, dit keer inderdaad eigenlijk.
Okay, so these are the kind of topics I'll be discussing today. So I'll be telling you a bit about my research in this area. So I've done a study where I'm looking at future research priorities for people living with dementia and hearing conditions. I'll also be talking about dementia pathways that currently exist in audiology services in the UK. And then I'll briefly discuss at the end the importance of involving underserved groups in research. So underserved groups include ethnic minority groups or other groups that tend to be overlooked in research at times. Okay. So I'll just tell you a little bit about myself to begin. As Clarissa said, I'm a senior research fellow examining dementia and hearing loss. I was also a carer for a loved one with dementia, and that led me to doing a lot of campaign work in Ireland, where I come from, with the Alzheimer's Society and with the National Dementia Office as well. So it's an area that I'm very interested in professionally and personally. And I just want to thank all the team who have been part of this research that I'll be presenting today. And also we've had great involvement from people who have lived experience of hearing conditions and dementia and of being carers, and also lots of great students as well. So I'll just tell you a little bit about dementia and hearing loss. Dalia is going to give you more in-depth information earlier about the links between the two of them. But just to tell you that the reason we're kind of interested in these two conditions is, first of all, they are very linked in the sense that a lot of people live with both hearing loss and dementia. Hearing loss is incredibly common. 1 in 5 people in the UK have a hearing loss. And in people aged 70 and over 70% of people have a hearing loss. So it's extremely common. And many people with dementia have hearing loss as well. And both conditions have a very similar impact or similar consequences. Not everyone with hearing loss will experience these things, but some do. So they can feel isolated, fatigued. There's a stigma to hearing loss. It can affect family life and work. And of course, it affects communication as well. And for clinicians, this is quite a challenge because the two conditions can sometimes mask one another or overlap. And that can make diagnosis difficult, and it can also make treatment quite difficult. So for example, if a clinician has a patient who has communication difficulties or difficulties concentrating, or they're uncomfortable in noisy places, it can be difficult to tell sometimes if that's due to dementia or hearing loss or a bit of both. Okay, so I'll tell you about a study I've been doing in the past year. The aim of that study was to set an agenda for future research about dementia and hearing conditions. So we wanted to find out what is the most important research that we should be carrying out in this area, because there's lots of research being done, but there's a lot more research that needs to be done in the future. So to do that, we did both focus groups and one-to-one interviews. And we did that with people living with dementia and or a hearing condition, carers and relatives, health professionals like audiologists, and also researchers who are interested in this area. So these are some of the results. So the results are looking at what priorities do people have for future research about dementia and hearing loss. So one thing that came up a lot was that people want us to understand different hearing conditions and auditory symptoms that people with dementia experience. They want to understand how common are these hearing conditions? Do they cause dementia or does dementia cause them? What is the link between the two of them? Is it that hearing loss makes you isolated and then you go on to develop dementia, or is there some other mechanism at work? So we just know the conditions are linked, but we don't exactly know why at the moment. And Dalia will be discussing that more later on. The other thing that people told us was that they don't just want to focus on hearing loss, there are other conditions as well. So some people have tinnitus, which is kind of like ringing or buzzing in the ears that can be very bothersome. Also hyperacusis, which is being quite sensitive to sounds. It might just be certain tones or certain sounds. Beyond a normal level, it can really interfere with your everyday life. And also some people with dementia experience auditory hallucinations. So that's important to look at as well. This is a quote from one participant. I have vascular dementia and Alzheimer's. My first sense to be affected was my hearing. Certain tones of noise physically hurt my ears. A wonderful audiologist programmed my hearing aids to dull the tones that physically hurt. I was walking in a different world. So that person was experiencing hyperacusis and they needed some extra care with that, but it is quite specialist. Not everyone knows about hyperacusis. Okay. The other priority for research was looking at what's the best way to assess hearing in people who live with dementia, and also what's the best way to assess cognition in people living with hearing loss. As we said, these two conditions can overlap and mask one another, and it's not clear what's the best way to measure them. We also need to consider how and when should we discuss dementia risk with people living with hearing loss, because we know hearing loss is a risk factor for dementia, but we don't know the whole detail behind that. And we have to be careful and sensitive about discussing risk with people who, you know, either have dementia or a carer or who potentially have hearing loss as well. Okay, a big finding was that we need to improve post-diagnostic support for people living with dementia and their families. I'm sure that doesn't come as a surprise. People would like multidisciplinary care, including linking in with audiologists, peer support counselling. Crucially, we need support for carers and education and training, and also potentially doing a hearing assessment when you first start to develop cognitive impairment or dementia, so people know your baseline and they can see if you need hearing aids or some sort of assistance. This is a quote from a gentleman who said, I was only 55 when diagnosed with dementia. I lost my job, I lost my driving license, I lost 32 years worth of friends. It was a huge, huge loss. You're basically left by yourself. Dementia affects my visual awareness, it affects my hearing, it affects my mobility. You don't know where to go. We also found that people would like to design and trial suitable interventions for hearing loss or hearing conditions, and also suitable practices in audiology clinics for people who live with dementia. These are some of the examples. I'll be discussing them more in a bit of depth in when I talk about my second study. Also, this was something that came up. It would be good to have a way to check out how the patients were cognitively before they began to work with hearing aids and how they are after using hearing aids for a certain time. This is a big area of research, but we don't have a clear answer yet. What is the impact of hearing aids on cognition? Do hearing aids slow cognitive decline or prevent cognitive decline? It's not clear at the moment. We also need to make sure that we develop interventions to improve social and mental well-being for people living with both conditions, because both conditions really affect your communication and your social interactions with other people. We also have to make sure that current care and interventions for dementia are suitable for people who also have a hearing condition. For example, music therapy or counselling or peer support could be affected by things like hearing loss and hyperacusis. A crucial one that came up a lot as well was training for health and social care professionals who don't have a good understanding of dementia or hearing loss. And sometimes even people who you would think might be a specialist, maybe someone you'd think specialized in dementia, might not have a very good understanding of how to communicate or how to interact with someone. So there's a training need there. And also families need education and support too. We also just need to tackle the stigma and all the misconceptions around these two conditions. I'm sure we're all familiar with them, things like they only affect very elderly people, or you know that they're very severe and you can't interact with someone. You know, there's so many false ideas out there about what someone with dementia is or what someone with hearing loss is like. A gentleman said, there's quite a stigma about dementia still, unfortunately. People are not sure how to react to you or how to speak to you. And we also need to make sure environments like hospitals, clinics and care homes are dementia friendly and hearing friendly. So these are some examples where possible. Reducing background noise is a big one, and also making everything very clear and very accessible. So for our next step, we're really excited about this. We're going to have what's called a James Lind Alliance Priority Setting Partnership. And this is funded by AOR UK and RNID. And this is where people with lived experience of dementia and hearing conditions, and also clinicians, get together. And they're supported by researchers to choose the most important unanswered questions about dementia and hearing conditions. And this will guide future research in this field. So future trials and future studies will be based on the priorities that these experts come up with. So we'll be launching that in around March time. So we're really excited. And if anyone wants to get involved, just let me know. My email will be at the end. I'll just briefly talk about a second study I've carried out, which looked at pathways for people living with dementia in audiology services in the UK. So we did a survey of audiology services and some follow-up interviews with audiologists. And we also did a workshop with people who live with hearing loss and dementia and carers. So these were some of the recommendations that they came up with for if a person with dementia is in an audiology clinic, what approaches should an audiologist use? So of course they should be person-centered, provide tailored individual support. They should involve carers and relatives, but they have to do that in a respectful, considerate manner. Ideally, everyone should have specialist training in dementia, because all people in the clinic will interact with people who live with dementia. They should also try and link in with other services and professions like care homes, GPs, the council, although there can be barriers to doing that. There should be enhanced follow-up care, because currently in audiology, most patients don't automatically get a follow-up appointment, and if they do, it might be over the telephone, which isn't really adequate. And then if you also have dementia, that's an extra difficulty. So some clinics, they take the initiative and book in follow-ups with people and call them back sooner and meet with them face-to-face. Clinics also adjust appointment lengths, but some of them have longer appointments, some of them want shorter appointments depending on the person. There isn't like a set appointment length that suits someone living with dementia. Some more recommendations were to adjust the testing that you do and to also adjust maybe the hearing aid fitting. You could also offer alternative tests to the usual ones that you would do, or alternative devices to hearing aids, or extra devices and extra tests. But there isn't really a standard practice that's done. Every clinic might do something a bit different depending on the patient. It's recommended that you don't penalise people for missing appointments or losing their hearing aids if they have dementia. And of course, create a welcoming environment and provide lots of extra information and try and get some information on the patient beforehand. There were, however, some challenges. So some people don't have any training in dementia, and some people do have training, but it's not very in-depth. It might just be one very short course. So we need to improve that. As I said, there's no real national guideline or standard that everyone is following. So some audiologists, they have to come up with their own procedures and own practices. There isn't really guidance for them to follow externally. Some clinics don't have a specialist pathway, they're a bit smaller. So that's a challenge for them. It's also difficult to measure how beneficial your treatments are in this population. There was a very small number who said they didn't provide hearing aids to people who had cognitive decline or dementia, which is really going against what the literature recommends. And then the role of cognitive testing is still up for debate. Some clinics do some cognitive testing, but some don't. And that's a big debate in the field at the moment. Okay, so I'll just finish off by telling you about our next study, which we're just starting out. So it's just to tell you what we're going to be doing. So our aim is to design a new toolkit, and we want to co-design that with people who live with hearing loss or dementia. And the aim is to improve the inclusion of underserved groups in this area of research. Because we know that minority groups, as I said, it could be ethnic minority groups, cultural minorities, the LGBT community. There's lots of different groups who have not been included in research. There are barriers in place that prevent them from taking part. So we want to change that. So these are some potential reasons why people from underserved groups are not included in research. They might not have trust in the healthcare system or healthcare research. We might not be very good at taking consent or promoting the study to them or giving them the right incentives to take part. So we want to identify what are the barriers in this particular area for hearing and dementia research, and then co-create this toolkit of different resources and strategy that can help remove these barriers. This is the process we'll go through. There'll be focus groups and workshops, and then a big celebration event at the end. People can take part in one step or several steps, it's up to them. And we hope that this will have lots of benefits. It will mean more people take part in research from backgrounds that tend to get overlooked. That will mean the research has more real-world applications. It's more beneficial and impactful. We'll start building a network of people who can take part in research and change things for the better. And it will enhance support and training for the workforce in research. So these are our funders and our collaborators I'd just like to thank. And if you have any questions about any of that afterwards as well, please feel free to contact me, or if you're interested in taking part or knowing more about what we do, please feel free to do that as well. Okay.
Fab, thank you so much, Eithne. So we'll have time for questions and answers afterwards, but if your brain is full of questions now, pop them in the chat, please, and we'll pick them up after Dalia's talk. And I still keep on admitting people, which is fantastic. So Dalia, presenter number 2, would you like to come to the virtual showroom and share your screen?
Okay. Are you able now to see my screen?
No, it's still with the full boxes of notes, etc. at the bottom. Could you go the other way that apologies about that, we're having some technical issues here. The other way you tried it before, where we saw your main slide and then the next slide, that might be a better view.
I have also sent the presentation to Eithne. Is it possible, Eithne,
Okay.
to share and to find the...
That might be easier.
Easier, yeah.
Sure, just a moment, please.
It's what you get from webinars, so just bear with us a little bit.
Yeah, I'm just waiting for it to come through. Oh, yes. To answer questions in the chat, I can send a copy of my slides afterwards if someone wants them, or I believe you'll be sharing the recording as well.
So yeah, we will upload the recording on our NIHR ARC Northwest Coast YouTube channel, and I'll send a link to that once that's done to everyone who's registered later this week. So you'll all have the link as well. So Dalia, whilst we're waiting and having that awkward moment of silence, do you maybe want to give yourself a proper introduction?
Yes, sure. Okay. I'm really nervous now because we have these technical issues. So
it's fine. Well, that's fantastic. The slides are up. Thank you so much, Eithne.
Thank you so much, Eithne. Yeah. So hi everyone. Really glad to be here today and talk about this very interesting topic. Thank you for having me here today. The recent years, as Eithne said, a growing body of evidence reports the association of hearing loss with dementia. And I'm excited to be here to share some insights on the link behind these conditions. My background is in psychology. I'm doing research in hearing health inequalities, and I approach the issue from a sociological perspective, from the perspective of social epidemiology, to understand the mechanisms. So I'm really glad to be here today to share some insights behind the mechanism, behind the link of these conditions. So I would like to begin by giving a brief overview of what I'll be discussing today. Next, please. Great. I'm going to cover three topics: the prevalence of dementia among people with hearing loss, the four current theories that try to explain the link between the two conditions, and the potential for the prevention of dementia through the treatment of hearing loss, which is a really important issue. Next, please. Hearing loss is a major public health challenge, and it is estimated that it affects the life of over 460 million people globally. Hearing loss, it is considered a major public health problem because the negative impact of hearing loss does not end with a person's ability to hear, as commonly believed. Losing the ability to hear can dramatically impact how one interacts with others and experiences life, because hearing loss affects communication, educational opportunities, work participation, and employability, and the whole participation in a family life, social life, and importantly, access to health services. So considering comorbidities of hearing loss is important due to the barriers in the use and access to health services as well. The figures for dementia show that over 55 million people globally may live with dementia. And the number will almost double every 20 years, estimated to reach 78 million in 2030. As I'm sure you all know, dementia has many physical, psychological, social, and economic impacts, not only for people living with dementia, but also for their carers, families, and society at large. Next, please. Now, a growing body of evidence the last years, particularly the last decade, supports the relationship between hearing loss and dementia, showing that those with untreated hearing loss are more likely to be diagnosed with dementia than those with normal hearing. More specifically, there is strong evidence that mild hearing loss doubles the risk of a person developing dementia, with moderate hearing loss leading to 3 times the risk and severe hearing loss 5 times the risk. Next, please. A new study published just a few days ago, led by researchers at the Johns Hopkins Bloomberg School of Public Health, found that older adults with a greater severity of hearing loss were more likely to have dementia, regarding the prevalence of dementia. The association of the two conditions showed that the prevalence of dementia among the participants with moderate or worse, moderate or severe hearing loss, was 61% higher than the prevalence among participants who had normal hearing. Next, please. In recent years, a growing body of evidence reports the association of hearing loss with dementia in the UK as well. Most studies have analyzed the data from the English longitudinal study of aging, which offers many ways to analyze longitudinally the progress of two conditions, both hearing loss and dementia. Next, please. A very influential report by Lancet, published in 2020, nearly 3 years ago, identified 12 risk factors, 12 key risk factors for dementia that are also potentially modifiable. These factors were less education, hypertension, smoking, obesity, depression, physical inactivity, diabetes, low social contact, and notably hearing loss. The researchers calculated that if all these 12 factors combined could be eliminated, up to 40% of dementia cases could be prevented. Hearing loss was one of the most significant contributors to dementia risk, and the report calculated that if all hearing loss cases were eliminated, up to 8% of dementia cases would be reduced. It is really important to understand the relationship between hearing loss and dementia. And the new National Study of Hearing in England, we published last year, showed that currently there are over 5 million adults over 50 years old in England with disabling hearing loss, over 35 decibels at 3 kilohertz hearing level. So if there is a way to intervene and eliminate hearing loss cases, if there is a link, a causal link, we will then be able to reduce dementia cases as well. So it's really important to understand this condition. Next, please. This is the study, 40 years on, a new national study of hearing. So you can see the update on hearing loss prevalence that shows that over 5 million adults over 50 years old in England and above have disabling hearing loss. Next, please. It is important to clarify, though, that the association between hearing loss and dementia does not mean that hearing loss directly causes dementia. Several theories attempt to explain the link, but to date, the exact association and, importantly, the relationship causal mechanism remains unclear. The cause of this association is unknown, despite there is a high prevalence of dementia among people with hearing loss. We don't know the exact cause, and there may be common factors causing both dementia and hearing loss, such as lifestyle factors, for example, smoking, alcohol consumption, genetic susceptibility, environmental factors, or age-related factors such as cardiovascular disease. So, how hearing loss is linked to dementia isn't yet clear, and studies so far point to 4 possible mechanisms, which I'm going to briefly present you today. Next, please. Okay, so I will go now through a very brief explanation of those 4 mechanisms. The first possible mechanism is that there is a common pathology that causes both hearing loss and dementia. In other words, this pathology affects both the cochlea and the auditory pathway, causing hearing loss, and the cortex, causing dementia. In this case, there may not be a direct link, but the reason behind the fact that those with untreated hearing loss are more likely to be diagnosed with dementia may be that the third factor affects different body functions simultaneously. Next, please. Okay. A second possible mechanism is that hearing loss can cause dementia by reducing brain stimulation. The idea is that the auditory deprivation due to hearing loss creates the diminishment of speech and language input in the brain, which negatively affects brain structure and function. This change in brain structure and function may be a risk factor for the subsequent development of dementia. In this mechanism, the first assumption is that hearing loss comes first and dementia follows, which is something we can't say for sure. And the reason is that the presence and severity of cognition can be misdiagnosed if hearing is not checked first. In addition, if we assume that there is a temporal relationship and hearing loss comes first, another thing to consider in terms of a poor acoustic environment is about which aspects of the environment are diminished in people with hearing loss. When we say hearing loss, we are really referring to 2 processes that are working simultaneously to allow individuals to hear in a given environment and for communication. So we have 2 terms, peripheral hearing ability and speech in noise performance. So people with impaired hearing receive less stimulation from the acoustic environment, but it may be the case that people with hearing loss have also less access to verbal and emotional information in speech, which is a really critical mediator of complex social interactions. So we may have direct and indirect changes. One possibility is that we have the direct changes due to the lack of verbal and emotional stimulation, and also alternatively, an individual may experience indirect changes due to the reduction in the quality of social interactions in which the individual engages. Next. In the third mechanism is based on the idea that people with hearing loss use greater cognitive resources for listening, making these resources unavailable for other aspects of higher cognition when they are occupied, in other words. What is important in this theory is that there is a fixed capacity for many general cognitive operations that are going on, such as attention, language processing, reasoning, working memory, all these cognitive operations. So these resources may be absorbed when listening becomes challenging and reducing the availability for other aspects of cognition. You may have noticed that in the previous mechanism, the problem was the decreased stimulation of auditory cognitive networks, while in this mechanism, in mechanism 3, there is an increased stimulation, which causes the problem, the increased stimulation from the increased listening effort, which may cause the issue. However, it remains unclear in this mechanism what is the mechanism, how these short-term difficulties, short-term cognitive difficulties due to increased listening effort, how this translates to long-term problems and long-term impact on cognition. So this is the limitation in this mechanism that does not clearly explain how this translates long-term. Next slide, please. To overcome this limitation, some researchers recently proposed a fourth mechanism that is based on the previous, basically, number 3 mechanism, but proposes now that the increased cognitive activity causes some pathological changes in the median temporal lobe in the brain, which are associated with the development of dementia. So they basically tried to explain why the increased activity can lead to synaptic changes associated with dementia. Next, please. Let's now see the potential for the prevention of dementia through treatment of hearing loss, which is a really burning issue, whether we are able to prevent dementia through treating hearing loss. So in case of mechanism 1 that focuses on a common pathology, unfortunately, treatment of hearing would not affect the development of dementia. The risk will persist because the cause is another third mechanism. In case of mechanism 2, hearing treatment could remove the increased risk of dementia, but if carried out early enough, before these changes on the brain occur, before the reduction in brain stimulation leads to significant changes in brain structure and function. So early identification of hearing issues is really key in mechanism 2. Mechanism 3 is about the overload of cognitive resources, which are occupied due to the use of greater cognitive resources for listening. Therefore, the support provided by hearing treatment would logically lead to risk reduction of dementia. Finally, the early treatment for hearing loss could reduce the risk associated with mechanism number 4 by restoring normal activity in the brain. But it is important to restore the brain activity before it is too late, before these changes occur. Next, please. You see, this is a very challenging issue, and I should point out that the possible mechanisms are not exclusive. We may have a combination of mechanisms, and also these mechanisms may explain different stages of the disease progression. A recent paper published just a few days ago proposes now that the mechanism that may underline cognitive decline may be different in different age groups, which makes sense, and this makes us understand that many different mechanisms may take place in different ages and in different stages of the disease progression. Next, please. So it is important to note that the association of hearing loss with dementia does not mean necessarily that hearing loss causes dementia. This is a really challenging topic, and there is a long way to go before we can fully understand this relationship. And I would like to also add that the causal linkage between hearing loss and dementia needs to be further investigated before we are confident to make any clinical guidelines and treatment recommendations regarding hearing loss as a modifiable risk factor. Next, please. In summary, in this presentation, I tried to give you a brief overview of the prevalence of dementia among people with hearing loss, the 4 current theories that try to explain the link between the two conditions, and some comments about the potential for the prevention of dementia through treatment of hearing loss. Next, please. While we are trying to understand the cause of link between hearing loss and dementia, we should also keep in mind that many people are currently living with one or both conditions. So it is important to pay attention on this as well, as our duty as researchers is to not only to understand and find answers and explain the mechanisms, but also to intervene and deliver actionable insights. As the old quote says, life can only be understood backwards, but it must be lived forwards. Thank you very much for listening.
Fantastic. Thank you so much. Thank you, both of you. Really interesting. And again, as I said at the beginning, something we haven't covered yet in the Dementia Forum. So it's great to hear about this aspect as well. I'm sure there's lots of questions. So please, everyone, pop your questions in the chat or your thoughts, personal experiences, etc. We'll pick them up now. But I just want to pick up on a key statistic there, Dalia, on the Lancet report a couple of years ago. 8%, if hearing loss cases were removed, 8% of the globally 55 million cases of dementia could be reduced. That's a substantial amount of cases. So if we reduce the hearing loss and provide proper treatment and prevention, that can have significant impact, can't it?
Yes, definitely. One thing only to note is that the figure says that these are potential mechanisms, modifiable factors. So we need to do more research to prove that these factors can actually modify dementia risk. So this is one thing to note. And another thing is that all these factors may be combined. So we may need to explore comorbidities of hearing loss with diabetes also that may are linked to dementia cases.
Mm-hmm. So we've got a few questions in the chat already. Again, as I said, just feel free to pop them in. And I think the first one might be a bit more for you, Eithne, possibly. Are there any particular cognitive assessments that have been found to support people living with possible cognitive decline and hearing impairment?
There are cognitive tests that have been designed, that have been adjusted for people with hearing loss. So, for example, if you were to go to a memory clinic or a clinic where you're going to get your cognition assessed, there is a version of some tests that have been developed for people with hearing loss, because a lot of them rely on having good hearing. And also the clinician should just do some basic things like ask the person, do they have a hearing loss? Ask them, are they wearing their hearing aid if they have one? You know, there's such basic things we could do as well, because they have found in the past that if you don't do those things and you give someone a cognitive test, their score would often be worse. Yeah. You know, they would appear to have a higher level of cognitive difficulty because the clinician hasn't taken the hearing loss into account. So yeah, there's been a few different studies, like for example, the Montreal Cognitive Assessment has been adapted for hearing loss, so that would be one example. But there's been some work in that, but it's now the work is about when should you do cognitive testing in people who have hearing loss, you know, and kind of what clinicians should do that. Should audiologists get involved in that? So there's some debate in that area.
Yeah, so maybe a wider multidisciplinary team assessment than it's usually being done, and also then answering Joan's question about should memory clinics be doing assessments on hearing loss, I suppose. So that's great. So another question is about mental health. Could there be a mental health link? That's a question, I think, to both of you, Dalia and Eithne. I.e. the loss of hearing is such a traumatic event emotionally, etc., that the depression it might cause would be a factor for dementia risk. Any thoughts from either of you?
It may be possible. So in my previous research, I found a causal link, causal psychosocial mechanism between hearing loss and depression. It may be the case that depression acts as a modifier of this risk. And I found that the depression was higher in those from low socioeconomic groups. So those from in the lowest socioeconomic position were up to 2 times more likely to develop depression. It is a very important question. I think longitudinal data would allow us to answer this, to be confident in this answer.
What about the ELSA? Have you used the ELSA data for this, maybe?
Yes, I have used ELSA data, all waves of ELSA spanning a period of 16 years. So I published a study about the causal mechanism of hearing loss and depression. So this is the first step. It's worth exploring whether the next step would be after depression to see the risk of people that have developed depression, whether they have a greater risk of developing dementia after depression. So I think it's worth exploring further.
Mm-hmm. I think in the question as well, the idea of, there's different types of hearing loss. Some people have a sudden hearing loss, which, might be more traumatic, and, also looking at depression, but other mental health issues like trauma as well, would be interesting. There hasn't been that much in that area. But yes, we know, I guess, that hearing loss and depression are linked, and both hearing loss and depression are linked to dementia. So it's certainly something worth investigating.
Mm-hmm. And for those people who are not used to the acronym, I've just realized this after I said it. ELSA means English Longitudinal Study of Aging. So people can apply for this long cohort data of middle-aged and aging adults in England. There's a question specifically for you, Eithne, on a more logistical approach for your work. How will you identify and recruit underserved populations?
Yeah, it's a big question because we're trying to improve that, but in order to improve it, we have to do it first. So it's a little bit maybe going about it in a funny direction, but we've got a great collaborator in the Centre for Ethnic Research, Centre for Ethnic Health Research in Leicester. We've also got some really great experts by experience who come from underserved groups who are working with us. There are other teams in the University of Nottingham who are doing some research, and someone posted in the comments about Bristol as well, so I'll check that out. A lot of going into the community, a lot of building relationships over time, making it beneficial and worthwhile for people, not just, kind of taking from people. We want to make sure it's something valuable for them to do. And we have some good links and some good databases that we're part of, and also some good links with charities. But if anyone has any ideas or wants to contribute, please feel free to get in touch.
Great. Dalia, well, it might be something for both of you, but I know, Dalia, you've worked at Manchester before, haven't you? There's a comment in there about the Manchester Biomedical Research Centre has a hearing theme. Are you aware of this?
Yes, of course. My doctoral fellowship was funded by this theme, NHR hearing theme. I wasn't aware that they have joined the Dementia Translational Research Collaboration because I moved from this department 3 years ago. So nice to know and get in touch with some researchers over there.
So unless there are any other questions or queries, I mean, both Dalia and Eithne are on social media as well, and I think both of them have shared the email, and if not, they will be in the recording and in the slides that we'll be sharing. So if you have any questions afterwards or comments or thoughts, you can get in touch with both of them, and I'm sure they're happy to answer any further questions. Eithne, would you be so kind to share the last slide, please, just to introduce the next upcoming webinar? It'd be fantastic. And I've already posted the link in the chat box as well.
All right, I'm just switching back to my one.
Fine. So the next webinar will take place on the 22nd of March, and you'll see the slides in a second. There we go. Oh, that's a bit overlapping. So I've shared the link in the chat box, and we will look at how can we improve well-being and quality of life for people with dementia and their carers, insights from a process evaluation. So our speaker will be Danielle Wyman. She's a final year PhD student working with Professor Claudia Cooper at Queen Mary University in London on the NIDAS project. So it's all about enabling independence at home for people living with dementia and their unpaid carers. So if you're interested, please sign up. But for now, thank you very much for joining. Thank you again, Dalia and Eithne. And I'm going to give you a virtual high five in the reaction boxes if everyone wants to do that as well. There you go. Nice little virtual clap. Thank you again for coming here, and I'm sure we'll see you around soon again. Bye, everyone.